Thank you. And John, you've given me a really good kind of intro into my talk. I'd like to start by thanking Frederick Jassel, who's one of my PhD students who's really helped with preparing this talk. So thank you, Fred. So I'm going to talk about bariatric surgery. Sorry, there we go. So I've already shown you this slide that we know that bariatric surgery causes marked weight reduction, and this is sustained, but it's rapid during the first 12 months. There's rapid improvement of comorbidities, improved quality of life, 40% reduction in mortality. And in terms of who is eligible, anybody with a BMI of 40 or more, or with a BMI of 35 or more with a comorbidity. But patients need to have tried lifestyle intervention, so a specialised multidisciplinary approach. And they also need to commit to long-term follow-up. The two major types of bariatric surgery are Roux-en-Y gastric bypass, shown on the left, and sleeve gastrectomy, shown on the right. There's limited access to bariatric surgery in the UK, with less than 0.1% of people eligible receiving it. In terms of risks, the mortality depends on the experience of the surgeon in the centre. There are some post-surgery complications, and patients need to take lifelong nutrient supplements. Now, I touched on this in my first talk. There is a wide individual variability in weight loss after both bariatric gastric bypass and sleeve. So each one of these lines is a person. What's clear is that the wide variation really stems from how much weight a person loses in the first year, so that's the weight loss phase, and then there's kind of weight maintenance after that. So does this variability in weight loss matter to the health of the patient? It does. So diabetes remission depends on weight loss and it being sustained, improvements in cardiovascular risk, cancer risk, and also overall post-surgery quality of life depend upon the amount of weight lost. So let's think a little bit more about this weight loss in the context of John's talk. So in addition to losing fat mass, after surgery, patients lose lean muscle mass and bone mass. This contributes to a reduction in energy expenditure, increased risk of falls and fractures, and also reduced physical function and strength. Patients will come back to clinic and say they can't climb up the stairs or put their arms above their head. So why is this such a problem? So we know that people with severe obesity are fairly sedentary. After surgery, they actually become less active because they're losing weight. They don't need to exercise. After surgery, they have poor protein intake, and often they have poor compliance with the supplements that we give them, including calcium. So how can we improve this? So if we protect the lean muscle mass, then the idea is that we will actually improve weight loss and weight loss maintenance, and also the physical functioning of patients. So can we increase physical activity levels? Can we ensure that patients have adequate protein? And how do we try and improve the adherence with supplements? So what's the evidence about physical activity in bariatric surgery candidates? Well, there are several studies, all of which have shown that people with severe obesity are fairly inactive and highly sedentary prior to surgery. Again, that's hardly surprising due to obesity stigma and actually the difficulty of finding gyms, etc., that will accept people with a BMI over 40. Most of the sort of NHS Tier 2 programs won't accept anybody if their BMI is over 40. Well, what about after surgery? Does their physical activity and sedentary behaviour improve after surgery? The answer is no. Actually, it probably gets worse because, again, for the first time in their life, these patients are losing significant amount of weight, so they feel that actually they don't really need to do any additional activity. So if we look at several studies, including the lab study, which is a longitudinal follow-up, we see that patients are highly sedentary after surgery. So we're spending up to 70% of their time in sedentary behaviour, with very little time spent in moderate to vigorous physical activity. So what happens if we try and improve exercise prior to somebody having surgery? So the Bariatric trial was a small trial, and they gave 6 weeks of exercise counselling to increase walking prior to surgery. So this improved moderate physical activity, but this was not sustained at 6 months after surgery. There was another RCT, quite a small one. Again, it found improved physical activity, but no impact in terms of post-op weight loss. And remember the variability that I showed you at the beginning. One of the things we're trying to do is to increase the weight loss and the weight loss maintenance. Obviously, physical activity prior to surgery does have benefits because it improves somebody's physical fitness, quality of life, and also in terms of the actual operation and the risk of the anesthesia, it improves their risk. So focusing on trying to increase activity pre-surgery is important in terms of the patient's health, but doesn't seem to have any particular benefit on the amount of physical activity and lean muscle mass preservation after surgery. So what about post-surgery exercise interventions? And again, there's very few data on this. And again, most of them don't start until 3 months after surgery, by which time patients have already lost 15% to 20% of their body weight, and hence lean muscle mass and skeletal mass. So there have been a couple of RCTs, one RCT with 33 people, again looked at supervised exercise, and they found some improvement in physical function and quality of life. There's also evidence that if you give exercise, then you improve lean muscle mass preservation. And also another RCT, which is I'm going to show in a little bit more detail, a 6-month supervised moderate exercise did improve insulin sensitivity, glucose and cardiovascular fitness, but had no benefit on weight loss. So this study, which was published in JCI, is the biggest one that's available, 128 subjects, and they were recruited 1 to 3 months after surgery. And they had 6 months semi-supervised moderate exercise, 30 to 45 minutes a week, versus standard care. The primary outcome for this was actually insulin sensitivity. They did muscle biopsies and looked at mitochondria. They found that moderate exercise improved insulin sensitivity and also improved cardiovascular fitness. There was an improvement in mitochondrial respiration, and also when they looked at physical activity, they found that the amount of body weight fat mass was greater in those who had more, who were more physically active. So suggesting that if we can improve physical activity after surgery, then we'll have health benefits. Now the question is, how do you deliver this at a population scale? And just to put it in context, at the moment, patients who have bariatric surgery, all of the efforts are focused pre-surgery, but not really post-surgery, when they need to really adapt to their new lifestyle. So NICE, when the NICE guidelines were reviewed in 2014, really put forward the need for high quality research to assess the impact of lifestyle interventions after surgery. So we undertook a feasibility study looking at the impact of a combined exercise, nutritional, behavioural intervention. And we found that by giving this, we improved functional capacity, we improved how sort of fruits and vegetable intake, and reduced the consumption of ready meals, and also patients reported an improved quality of life. The participants themselves really enjoyed the exercise sessions and were keen that we could develop this for other patients. So we're just about to come to the end of our randomized controlled trial, where we recruit people prior to surgery. They're all given wearable trackers, and we also then do actigraphs, and they're randomized to either standard protocol at the moment, which is 3 monthly follow-up, where they're advised about physical activity, but it's not really pushed, versus counselling via telephone that starts literally from the day of surgery. So from the day of surgery, we really support them in terms of physical activity, protein consumption, and taking their supplements. Then they have a supervised exercise session, which was face-to-face, but with COVID has moved to virtual. And then they have ongoing counselling out to 12 months. And we've undertaken DEXA scanning upon these participants and also assessment of physical activity. And as I say, we're due to finish this in January. So I'm hopeful that actually this is a mechanism by which we can deliver at scale post-operative lifestyle behavioural intervention to patients after bariatric surgery, and hopefully reduce some of that variability and also maintain long-term weight loss. So in conclusion, we need to be doing physical activity counselling pre and post surgery. Most bariatric programs don't have exercise therapists or physiotherapists, and they should, and we really should be trying to encourage physical activity. Here are the acknowledgements. Again, thank you to Fred for helping put these slides together. Thank you very much.